The analogy I actually like to use is imagine that the brain has hardware, it has software, and then we have the cloud. So the hardware is the structural parts of the brain, right? And clearly from what we just saw, the structural parts of her brain are they're not functioning properly. The software, I would say, is the psychology, right? The schemas, the beliefs, the character, and then the cloud, I would say, is the spiritual, the metaphysical, right? So we have the hardware, we have the software, and we have the cloud. What I find after doing this for 44 years is that lots of problems are really in the hardware and in the cloud, and that for most people, the software is pretty good. If it's not good, they have to do some work on character development, maybe work on some schemas, but it's very hard to develop your character and have a good attitude about life when your hardware is malfunctioning and you don't have the resources of the cloud.
I'm thrilled to welcome one of the pioneers of integrative mental health and functional medicine psychiatry, the wonderful Dr. Bob Hedaya, who's been at the cutting edge of psychiatry and psychopharmacology since 1979. He's actually experienced both sides of the coin, having practiced as a conventional psychiatrist and psychopharmacologist, and then having discovered functional medicine and being convinced of its undeniable results, he switched to practicing and teaching functional medicine psychiatry. With the publication of his first book, Understanding Biological Psychiatry, he pioneered the use of functional medicine in the psychiatric field, and he's now pioneering the use of Hylane technology in the treatment of neuropsychiatric disorders, which we are very excited to learn about today. Dr. Hedaya is a clinical professor of psychiatry at Georgetown University Medical Center, where he's been awarded the Teacher of the Year on 3 occasions. He's a faculty member of the Institute of Functional Medicine, IFM, and the founder of the Whole Psychiatry and Brain Recovery Center. He's been featured in the local and national media, including 2020, 60 Minutes, Vogue, the New York Times, Washington Post, etc., on many occasions, and is a frequent nationally and internationally recognized speaker. So we're absolutely thrilled to welcome Bob Hedaya, Dr. Bob Hedaya, and he's going to tell us about some really pioneering therapies in functional medicine, and we're thrilled to welcome you. Thank you so much, Dr. Hedaya, and thanks for being here.
Hi, Kiki. Thank you for having me. It's a pleasure to be here. I'm really honored, and I look forward to the opportunity to share exciting new developments in the integrative psychiatry, whole psychiatry field. I really think people can find it very helpful. We're going to dive right in. The main question that we're going to be addressing today is, well, what does functional medicine do for the brain, and what is it? What can it do, and what can't it do? And if there are things that it can't really treat, how do you deal with it? So the question here is, how effective is functional medicine in normalizing brain function in these neuropsychiatric conditions and others, but these are the ones we're going to cover today. We're going to talk about treatment-resistant depression, traumatic brain injury, OCD, PTSD, dissociative disorders, neurodegenerative disorders, aphasia, temporal lobe epilepsy, as well as specific neuronal deficits like prosopagnosia, which is facial blindness. So that's what we're going to be focusing on. The first case that really introduced me to this realm was this woman who was 58 years old when I started to see her. And she came to me with this history here. She had 5 first-degree relatives with ApoE4, the risk factor for Alzheimer's disease, 2 aunts with dementia. She herself was actually homozygous ApoE4. And this is her timeline. As you know, in functional medicine, we look at antecedents, triggers, and mediators of disease. Well, this is her timeline that helps us to understand these things. And you can see at age 4, she had a traumatic brain injury. She was unconscious for several hours. It actually was her father who injured her. So you know that there was a really abusive relationship, which we know with the studies on adverse childhood experiences increases risk for all kinds of chronic illnesses, including depression, including dementia, including metabolic syndrome, inflammatory diseases, autoimmune diseases, etc. So this is age 4. Age 24 to 51, she's drinking, I'd say, moderately, heavily 3 to 4 drinks per night. At age 30, she has a toxic exposure. Wait a second here. I'm sorry, the slide popped in here. Sorry, there we go. At age 30, she has a toxic exposure. And at age 46, she has depression. Well, very interestingly, at age 50, she goes into menopause. So this depression at age 46 was likely the perimenopausal factors playing into her situation. So that by age 46, she's having her first clinical depression. Now, no doubt she had depression before, but never to the degree that she needed to seek help. But at age 46, she did, and likely, my guess is her hormones were starting to go down, affecting her cognitive reserve. And by age 50, she's in menopause. And age 51, she develops facial blindness, called the word for that is prosopagnosia. So she couldn't recognize faces. And then this is a woman who had her own business, and she needed to recognize her clients. So instead, she began to take copious notes on everything that she did and the people that she would meet with. And that's how she was able to continue functioning. But she really had a severe problem. And she had also noticed impaired memory, word recall. And at that point, she got afraid and she stopped drinking. And by age 54, she noticed accelerated cognitive decline, and she sought neurological consultation. They diagnosed mild sleep apnea, which they treated. And that was the extent of what they did. Now, when I saw her, she had a variety of abnormalities on her physical exam. Her MoCA, the Montreal Cognitive Assessment Test, was 27 out of 30. So it's a mild impairment. Mental status exam otherwise was normal. And when I told her, we're going to have to do a thorough functional medicine treatment, and it could cost you a lot of money. It could cost you $30,000, $40,000, $50,000 with all the testing and all the appointments, et cetera. She didn't really have insurance that would cover her. And she said, I've got about $50,000 in the bank, and I'm going to do what I have to do to save my brain, because without my brain, I don't have anything. So she did, and she was exceptionally compliant. And we treated a number of things in the functional medicine matrix, including her thyroid. Now, this is important. You would look at her TSH at 3.34, and you say, well, that's pretty normal. 0.45 to 4.5 is normal. Well, the mean TSH in the US population is actually 1.5, and that's from the NHANES study with over 16,000 people. So obviously her pituitary is working harder to get her thyroid to function. I did over 100 TRH stimulation tests, early 90s, and found that as the TSH rises above 1.4, you're much more likely to have hypothyroidism in higher and higher amounts. So for someone with cognitive problems, and knowing that free T3 is actually very important in cognitive function, that TSH is worrisome. Now, you want to correlate that with her symptoms, obviously, a physical exam, and the free T3 and the free T4. But in her case, also looking at her genetics, her deiodinase enzymes, and how she converts T4 to T3 in the brain, we decided that to go ahead with thyroid treatment, as well as some other hormonal treatments. This is her timeline, again, in a visual form. It's just kind of really important to remember that depression is actually, when a person has a depressive episode, they're at 30 to 50% risk of developing mild cognitive impairment or dementia later in life. So the depressive episode is actually a precursor to neuropsychiatric disorders later on, because of the shared mechanisms that are involved causing depression and neurodegenerative diseases. So here's our timeline, and what we did basically is a thorough functional medicine treatment involving diet, using hormones like estrogen, progesterone, testosterone, and treating her thyroid. She actually had recurrent hypothyroidism. She kind of go in and out of hypothyroidism. Detox her from mold, organotoxins, lead, which is ongoing because that's a very slow process. She had iron overload, central apnea, which we had to monitor and treat. And she also had babesiosis, which tick-borne illness, and we treated that as well. So it was pretty thorough. She was very engaged in the treatment. And after 6 months of a thorough protocol, she was feeling much better. able to make decisions. Her mental fog is gone. Disability, her ability to function was excellent. Her business was doing well, but she still had distractibility. She still had a lack of focus, and memory, short-term memory was impaired. Better, but impaired. Word recall, better, but still a problem. And facial recognition, better, but still a problem. And peripheral vision, somewhat better. So she's doing better, working out every day, doing better, and pretty happy. Now, at this point, I had been studying qEEG and transcranial photobiomodulation, which we'll talk about, or laser therapy for the brain, for a couple of years, and was ready to actually use it in the clinical practice. So she was actually my first patient. I said, well, she's doing better, but she's still having symptoms. I wonder what her brain looks like, right? So how's her brain doing? This is the question, you know? And so what we did is a 19-channel quantitative EEG, which I'll explain to you. This is a functional test. It tells you about brain function in real time. It's not like an MRI. It's not a structural test. It's a test of function of the brain. How is your brain functioning right now at this moment? And this can be done, and we can do this in a person's home. It takes about an hour. We can do it in the office, do it anywhere in the country. And this is very well accepted. The qEEG, quantitative EEG, has established validity, reliability. It correlates with diffusion tensor imaging, functional MRI, volumetric MRI, superior to SPECT scan, as you get a lot more detail, as you'll see. It's very interesting because neurologists, the neurological societies, actually reject this. Well, now they don't reject it, they become neutral on it. But this qEEG actually uses artificial intelligence, right? So if you have a regular EEG with a neurologist, they eyeball the tracing. And as you're going to see, the tracing is quite complex. And they eyeball it and say, well, you know, the rhythms look pretty normal here or there. But this quantitative EEG takes the data, processes it through a very sophisticated algorithm that's been developed over many years through National Institute of Health. It's quite sophisticated, and the computer, the algorithm, will detect things that the eye cannot see. You will never know the things from looking at the EEG that you can know from a quantitative EEG. So it's extremely, extremely sensitive tool. This is what a tracing looks like. So we put a cap on the person's head, and the cap has 19 points where it contacts the skull, and each point of contact is measuring the electrical output of that area. And through something that's called the inverse solution, that electrical activity is actually able to be converted so that we can understand what the different areas of the brain are doing. So it's kind of like if you put a cap on a balloon and you want to know what's going on deep inside the balloon, we can actually know what's going on inside the balloon by reverse engineering, in a way. It's called the inverse solution. Through a sophisticated, highly sophisticated algorithm, and we can detect what's going on in different areas of the brain in great, great detail. In this particular qEEG, this is her qEEG, the 58-year-old woman. And you can see here, this is this particular lead here is this signal is going down. Here it's going up. This is called a phase reversal. And the phase reversal is a pre-seizure indicator. It doesn't mean she's having a seizure, but there's a pre-seizure indicator. And this spurred me on to ask her more about her whether she had any seizure disorder. In fact, she had absent seizures, which were never diagnosed, which was quite interesting. Now, the other thing down here, what we see here, anything above 2 is abnormal. You can see some areas of abnormality here. And what we have on this lower axis here is the frequencies that we measure. We're measuring what the neuronal populations are doing in the brain at different frequencies from 1 to 30 hertz. The hertz is 1 cycle per second. We're measuring what's done 1 cycle per second, or 1 hertz, 2 hertz, 3 hertz, 4 hertz, all the way up to 30 hertz. Now, each of these frequency bands have different functions. So 1 to 4 hertz is called delta. It's slow waves. And oftentimes these are unconscious processes like slow wave sleep. That's where you often will see head injuries. And these are unconscious processes. And then you have, then you have theta, and theta is the emotional frequency, let's say. So it's 5 to about 9 cycles per second, 5 to 9 hertz. Theta is how you're doing emotionally. It's also a measure of the cognitive load. If you're doing something and you can't process things, your theta may go up because you're stressed by it. And then we get into the beta, the alpha, actually, alpha 1, alpha 2, which is basically 10 to 12 roughly, and this is the relaxation band. And then we get into beta, and beta is divided into beta 1, beta 2, and beta 3. And beta is where you're faster. You're going, say, from 13 to 30. And of course, these populations of neurons are firing more rapidly. So, that's your fast thinking. That's your anxiety, your fast processing. So beta is your fast processing and your thinking and your worry. It can also be muscle activity. It can be an artifact that you might see. So basically, we like to see that the energy produced here, or let's say the power produced by these different populations, is under 2 standard deviations above the zero, above the norm here. This is the median right here. And we like to see things above the norm, below this 2 as a general cutoff, which is a little bit extreme, but we like to see that. Here's a peak frequency with her eyes closed, and you can see her peak frequency of energy and power is here right about 11 and a half or so. And that generally is a sign of a faster working brain, more intelligence, not absolute, but more intelligence. That's kind of an overview. It's a lot of wiggly, zigzag lines, and you can see, you can analyze this visually, but when we process it through the algorithm and through the artificial intelligence, we get a lot more information, and this is what we get. This is her qEEG processed through this algorithm after functional medicine and before the Hylane treatment, which is what we're going to focus on today. So what you see here, here's a woman who went through functional medicine, and you can see that her brain is not really functioning normally. Now, the way this works here, just to orient you, the eyes are here on this area here. Her eyes, you can actually see. Ears are here, the right side, right side, left side is the back of her head. Anything that's yellow or blue or red or orange is actually abnormal. Now, in this case, the orange and yellow is where brain areas are overactive. Now, the brain spends most of its energy actually with this putting the foot on the brake. The brain spends most of its energy inhibiting firing. So the gray is normal, and these areas are firing too easily. This is the olfactory bulb here near the nose, right? And there's excessive firing here. That could be because there's not enough energy in the brain, or that could be because of something irritating the brain, or inability to maintain stability in the brain. Now, these crosshairs here, the red crosshairs, are telling us about a specific area in the brain, which I will get to. This is a lateral view. You can see the eyes here. You can see the base of the brain here is these areas not functioning, even the visual area here. And then here on this is a coronal view. The ears over here, there's the left ear, there's the right ear. The nose would be coming out towards you, and the back of her head on the other side of the screen. And this arrow here, these 2 arrows here, are her hippocampi, which control memory. And we know the hippocampi are strongly affected by the ApoE4 genes in Alzheimer's disease, right? And so what we see here, after functional medicine, her hippocampi are still abnormal. And if we look here on the lower right side, you'll see the hippocampus on the left is the worst area, and its maximum value is 2.7 standard deviations from the norm. So it's significantly abnormal. In this last area here, this last quadrant here, we see information flow. The information between specific Brodmann areas, and we can expand this and see, well, this Brodmann area, let's say it's area 17, the surface of the brain is actually divided up, and we'll go over this a little later, into different areas called Brodmann areas. Brodmann is the one who developed it. So these are Brodmann areas. And the back of the head here, 17, 18, 19. Let's just say this is area 17. How is it communicating with other areas? How's the information flowing? Is it flowing too fast or too slow? In this case, the yellow and these little orange areas are showing us that the information flow is excessive, and the blue is telling us that it's very slow. Now, excessive and too rapid information flow is not good because there's a poor synchronization between areas, and the same problem with slow information flow. So this is poor information flow after functional medicine treatment. The last thing I want to show you here is area 11, in Brodmann area 11 here, circled here. Brodmann area 11 right down here inhibits, it's the orbitofrontal cortex, and that inhibits the emotional brain from getting overly active. And you can see her Brodmann area is, well, you can't see it exactly here, but you'll see it elsewhere, is actually dysfunctional. So this is 6 months into functional medicine treatment. And when I saw this, I guess I was disturbed because she was doing better, but obviously her brain was still not normal. This is actually a slice at 6 hertz. You see the 6 up here. 6 is in the theta range. That's where we'll often see abnormalities in people with dementia or emotional disorders. So functional medicine is in place. A lot of symptoms are improved, but brain is objectively abnormal in function. So you've repaired the terrain, but not the brain. What do you do? The analogy I actually like to use is, imagine that the brain has hardware, it has software, and then we have the cloud. So the hardware is the structural parts of the brain, right? And clearly from what we just saw, the structural parts of her brain are not, they're not functioning properly. The software, I would say, is the psychology, right? The schemas, the beliefs, the character. And then the cloud, I would say, is the spiritual, the metaphysical, right? So we have the hardware, we have the software, and we have the cloud. Obviously, in our world, the cloud is actually just giant hardware. But for this analogy, it's the cloud. And that's how I kind of look at things in terms of neuropsychiatry, what's going on in the hardware, what's going on in the software, and in the cloud, in the spiritual, psychospiritual realm. And the social realm, etc. And so what I find after doing this for 44 years is that lots of problems are really in the hardware and in the cloud, and that for most people, the software is pretty good. If it's not good, they have to do some work on character development, maybe work on some schemas, but it's very hard to develop your character and have a good attitude about life when your hardware is malfunctioning and you don't have the resources of the cloud. So here's where she was before the Hylane treatment, and here's where she is after the Hylane treatment, the therapy treatment. And you can see here, everything's gray. That's completely normal. Here's her hippocampi. We're still at 6 hertz, exactly the same brain regions that we're looking at. Her hippocampus now is completely normal, right? And well within the normal. You can see 1.2 standard deviations from the norm, so well within the normal, and her information flow is dramatically improved. Still some areas of problems, but really dramatically improved. And she's doing great with this treatment. And it turns out we did this about 3 months after we stopped the treatments, and we did this 3 months afterwards, and she actually regressed. And so clearly because of her ApoE4 vulnerabilities and what's involved with that, she needs maintenance treatment. Not everybody does, but she clearly does. My last contact with her was about 6 months ago. She was off to Europe, business still thriving, doing very well, maintaining her treatments. So that's it. I was pretty blown away by this when I saw this. I thought, actually, I should go back and tell you what happened here. The first treatment that I gave her with the laser, I decided where to treat her based on the qEEG. Now, at that point, the prosopagnosia, the facial blindness, was not even on my radar, I have to say. If you told me she has prosopagnosia, I would have said, what's that? It didn't register for me. I thought she had mild cognitive impairment and she had absence seizures, but I wasn't really thinking or cognizant of her prosopagnosia, even though it was having a major effect on her life. So I treated her with the first laser treatment, and she came into my office and she actually sat down, and she says, and you'll actually hear a recording of her at the end of the session here, and she says to me, "Oh my God, I can remember the face of the person I treated this morning. Oh my God, I remember the face of his wife, and I remember." So her prosopagnosia was gone after one treatment. This made no sense to me. I couldn't understand this at all. I was astounded, and just my mind was blown. It was incomprehensible to me that a neurological condition with one treatment could go away. Now, what I later came to understand is she had cells in her brain that were injured, but they were in a liminal state, meaning they weren't functioning, but they were alive. When we provided energy with the laser, they came alive and they were able to function. And actually, her prosopagnosia was healed, and it never came back. I did an objective test because I couldn't believe it, and she did this Cambridge face recognition test, and she scored about 80% correct, and the average score is, or she was 72%, so average score is 80% correct. This is a massive improvement in facial recognition. So I was so blown away that Joel Lubar, who helped me interpret this qEEG, and we published this paper on this is basically the first case reversal of acquired prosopagnosia using quantitative EEG guided laser therapy. And we've actually reversed partially, like 75%, 2 cases of aphasia, which is difficulty finding words, sometimes difficulty understanding language as well, and other specific, like specific visual deficits by targeting specific areas using the laser. So that's the first case. Later, I came to build on this and have come to 4 technologies that we use, and we call it Hylane KAP. The Hylane we'll go through, and these are all personalized. They're stackable. You don't always use all of them in every patient. They can actually precede the functional medicine or be layered on functional medicine. In her case, I layered it on functional medicine. And I always thought that you had to do that. However, a patient came to me about 2 years ago with early dementia, or maybe even mid-stage dementia, and she was aphasic. And her husband was begging me to treat her, but I said, she really doesn't want treatment. She didn't want to change her diet, didn't want to exercise, et cetera, et cetera. And finally, he prevailed upon me. I said, well, I'll try the laser. And I didn't do any functional medicine treatment. And I was sitting in my office, and I was making her laser plan, and I just said, God, I need a miracle. Went into the laser office, lasered her in a specific area, and she started talking. And both he and I had tears in our eyes, and actually her aphasia was reversed by about 70%, 75%. I was able to have a 45-minute therapy session with her. She was that verbal, in which she actually talked about trauma that she had from her mother, which was, and other trauma. It was quite astounding that these things probably set her up, along with genetics and diet, et cetera, to her dementia. So it's pretty profound. So what is Hylane? Well, it's hyperbaric oxygen therapy, which many of you have heard about. The quantitative EEG guided laser, neural exercises, and ketamine-assisted psychotherapy. So what we're going to do is kind of go through these and incorporate into our discussion some of the research and some cases of each one of these, so that you get a sense of what is involved here. So hyperbaric oxygen therapy basically is high pressure therapy where you have ambient pressure greater than normal. And so we're using a soft chamber in our office. Some people use hard chambers. We use a chamber that goes between 1.3 to 1.5 atmospheres. That means you're in this chamber and you feel like it's kind of like being 10 feet underwater. That's the level of pressure. It's very mild. And we use it always with supplemental oxygen. We use the Afradi protocol developed in Israel. We didn't always use that, but we're using that, and that's basically using as close as you can get to 100% oxygen for 20 minutes. Then we remove that. We keep them in the chamber with the oxygen, but it's not on the mask is not on their face. And the brain develops a sense that it's a relative hypoxia, even though it's not. And then they're mechanisms that over time will become activated by this, and it seems to be more helpful. So that's hyperbaric oxygen. These are some of the chambers. There are many companies making these chambers. You can lease them to buy. You can buy used ones, etc. This is an oxygen concentrator, and that's what helps to bring you the high volume of oxygen into the chamber. And we have them, a couple of them in the office. We have a chamber that is suitable for 2 people, useful for people who are elderly or people who are afraid to be in there alone. Now, there are traditional uses of HBOT, which I'm not going to go into, but they're all approved. This clearly helps with tissue recovery, etc. And there are emerging applications of hyperbaric oxygen, like traumatic brain injury, which we're going to talk about, autoimmunity, neurodegenerative disease, autism, PTSD. In Israel, they're finding a lot of that with the Fradi protocol, stroke, sports medicine, cancer, COVID-19, and even augmentation therapy, and even people with liver disease. So these are some of the emerging applications, right? So how does it work? First of all, it reduces oxidative stress, particularly when you use the lower pressures below 2 atmospheres. And you can see it increases the activity of all of these enzymes, the superoxide dismutase, catalase, glutathione, peroxidase, etc. So there is a kind of a metabolic effect. But in addition, we have, and this is really the most obvious, right? We have an increased zone of nutraceutical and oxygen delivery because you're under pressure. So a lot of the time, and particularly post-COVID, we're seeing this because of the vascular problems. A lot of times the capillary perfusion is impaired. You can see it on a physical exam. People have mottled skin, and their capillary perfusion is impaired. And so the hyperbaric oxygen is going to, with the pressure, going to push more nutrients, more oxygen into the distal tissues, giving them what they need so they can function. The red blood cells become more flexible, make more ATP after acute insult, according to animal studies, and intracranial pressure will go down, blood flow goes up, and even stem cell production goes up. So it's quite an impressive thing. Now, the mechanism in Hylane, each of these things has a different mechanism. This is a mechanism that's kind of global, delivering nutrients to the tissues, delivering oxygen to the tissues, improving reactive oxygen species function, and improving stem cells. So that's one mechanism of action, right? Let's look at the effect on TBI. Okay, there's a meta-analysis of I think there's 8 studies of people with traumatic brain injuries comparing the effect of hyperbaric oxygen therapy versus control in patients with mild to severe TBI. And they used a couple of outcomes. The Glasgow Coma Scale was the primary outcome, and the Glasgow outcome score was the secondary outcome in PTSD. And mortality, changes in PTSD, all improved. The result of the 8 studies reveal higher post-treatment GCS Glasgow Coma score in the H5 group. So this is good, and it's highly significant, p.001, and greater improvement in the Glasgow outcome score and lower mortality compared to the control group. That's impressive. So this suggests that TBI, this should be a standard of therapy for people with TBI. So now this is what's really impressive to me, that the HBOT can improve post-concussion syndrome years after mild TBI. Now, and this is from randomized prospective trial. Now, how many of you ask your patients about TBI? I know I didn't 8 years ago. I wasn't asking. People will tell you, no, I didn't have any injury. Well, you fall down a flight of stairs off a bed, that's a traumatic brain injury. Maybe you didn't have a loss of consciousness. Important to note that when you're a child, you can have a traumatic brain injury. Part of the brain can be injured. You may not even see symptoms. Okay, but when the brain reorganizes in adolescence and that area that was injured can't be integrated into the other networks, you're going to have symptoms developing at that point as a result of TBI from years before. So here's a study that shows the changes in people with TBI Specific areas, information processing, attention, you see the red bars here is the HBOT group. You see the improvement here, attention, executive function, memory, very specific areas. And it's very interesting that the HBOT has specific benefit in particular areas of the brain, like the frontal lobes, the dorsolateral prefrontal cortex, Brodmann area 45, 46, executive function, planning, organization, judgment, might show up with ADD, right? If you have an injury there. Frontal lobes, Brodmann area 11, which is the orbitofrontal cortex, which inhibits emotional outbursts. And, when Brodmann area 11 is not working, then you have disinhibition of the emotional control outbursts. And then area 38, temporal lobes, is involved in dissociation, common in the neuropsychiatric field. And then area 39, which is self-awareness, awareness of what people might be thinking, etc. So here is a SPECT scan showing the pre and post, differences and percentage of change in in people with traumatic brain injury. And what you see here, very specific areas. Here's the anterior pole of the temporal lobe, as we talked about, the dorsolateral prefrontal cortex. These are the areas in red and white that are most impacted by the hyperbaric oxygen, right? So that's very interesting and fairly specific, right? Here's a patient that I treated she was an athlete, high-level athlete, and there's her qEEG. This is gray, again, just to reorient you. The gray is normal. Here are her eyes. Blue is under-functioning. You can see here a line of demarcation from her head injuries, like a compression wave, right? And you can see how abnormal, and the frontal lobes are not functioning, right? They're under-functioning. They're excessively stable. And so she's obviously having a problem. Now, she has alcohol abuse and traumatic brain injury. And as a result of these things, she developed a bipolar disorder late in life. So it was induced by mostly these two factors, right? So this is after she was treated with hyperbaric oxygen and neurofeedback. And you can see that whole frontal area is now normal, right? So as that study showed, the hyperbaric oxygen was actually able to normalize this, and the neurofeedback actually helped with the connectivity. And she still has these blue areas showing impaired connectivity in some areas, but this is very mild, and she actually did very well. So you can see that there's clear benefit here. Okay. Now let's go on to the next slide here. Risks and contraindication of hyperbaric oxygen. So barotrauma to the ear. Signs is you can't go into it if you have congestion and if you can't clear your ears. Pneumothorax in the last year. I don't know about hypoglycemia. That's questionable. Seizures, questionable. For babesiosis, I would say don't put someone in the hyperbaric oxygen chamber because the babesia like oxygen. All right, laser. Let's talk about laser. We're going to go on to the next one, the photobiomodulation. Okay, so we're basically PBM, photobiomodulation. It's the modulation of living brain tissue using light, and there are two broad approaches. One is using a laser, which is what I use, which is coherent, meaning synchronized light, collimated beam, high power. And then there's light emitting diodes, like what you might have in a light, on a lamp or in your phone or something. These are LEDs. They emit non-coherent light at a very low power. There's a debate about penetration of this, but the studies do seem to show that these LEDs can help brain function in various conditions. The question is how. There are remote effects, there's the heat effects, electromagnetic effects. Is the light penetrating to some degree? The studies are done by the companies that make the devices. The people who are making these devices are very excited about it. They're very sincere, and they're really working hard to understand what's going on. But as always, like we know with pharmaceuticals, we want studies that are done by third parties so that we can have objective evidence of what's going on. So this is the laser that I use. It's an Aspen laser. There are lots of different types. It's a class 4 medical device. These are just a couple. There are lots of different LED devices that we have. This particular one here can focus the low power light in different areas a little more specifically than this one here. It's quite a contraption, but there are a lot of development. Actually, the field here is moving along fairly quickly. Okay, where these are some of the uses of the laser: neurodegenerative disorders, TBIs, PTSD, depression, ADHD, stroke, and really, it's an expanding list. How does it work? Well, the main way it works probably is by releasing ATP, the energy molecule, almost immediately. Now, there's a therapeutic window. If you give too much light, it doesn't work. Too little, it doesn't work. So the way it works is the mitochondria, you have the citric acid cycle that feeds, glucose basically into the mitochondria. And that goes down the electron transport chain, which involves 4 stops. The last stop is a pore or a channel. And basically, that channel produces ATP, the energy molecule. Without ATP, we're all dead. At the outside portion of the channel is a nitric oxide molecule. You could think of it as a little golf ball sitting at the outside of the channel, kind of regulating the flow of ATP. You apply the light, and the photon knocks the nitric oxide off the channel, and ATP can flow. So now you have energy flow. Now the nitric oxide goes and diffuses, and that's actually causes vasodilation, meaning increased blood flow. So now you have energy and you have blood flow, right? And then you have the nitric oxide also acting as a retrograde messenger to the other cells that are neurons around, and in some areas of the brain, like the hippocampus, they actually induce long-term potentiation and improve area CA1 region of the hippocampus involved in memory. So these are the primary mechanisms. Basically, it's ATP, nitric oxide. There are other mechanisms here. You have certain genes are activated, growth factors activated, reactive oxygen species activated, and neurogenesis, et cetera. So, and then I think there's a downstream effect, which I think, while you give the cells energy, right, and now they can do the repair work that they need to do. They can function, but they can also do the repair work. And we saw in that first case with one laser how the cells that were in a liminal state responded very quickly. They just need to be waken up, and they were able to function. When you're working inside the brain with the laser, you need to consider all of these factors. Where do you apply it? How much do you apply? How much energy? What wavelength? Do you pulse it? Do you use continuous wave? Is it penetrating or is not penetrating? How much pigment is getting in the way? How often do you treat? And you want to measure the tissue response, right? And you want to also respect that there's a therapeutic window. So there's a number of factors that have to be involved. We determine what brain regions we're going to treat and networks by looking at the qEEG and the symptoms and seeing where they overlap and where we have to go first, right? And then we target those specific areas with the laser, and then we go from there. So this is the qEEG again, just to reorient you. This is a map of the 19 areas. The nose would be here. This is the frontal areas, the occipital areas. This is the right ear, left ear, and each of these areas has a established number that we use, and then we can correlate these to the different Brodmann areas using different symptoms, and we know where we're gonna attack or treat. These are the different Brodmann areas. There are lots of different maps of this. Here's a case, a laser case. This is a guy who had 28 years of depression. This is mood chart at baseline here. You see the baseline, dark black line is normal mood, but he doesn't achieve that very often. This is 1 month from January 9th to February 5th. And you can see how he dips down even to suicidal at times, right? Not doing very well. And this was his baseline. I worked him up for functional medicine. You can see the list of all these things: alcohol, gluten, iron, copper, mitochondrial dysfunction, methylation defects, etc. He was very isolated, etc. So we treated all of these things. And then this is where he's at after the treatment, right? So you can see there is an improvement here. He achieves normal mood, and he's not really suicidal anymore. That's down here, right? Well, maybe a little bit or getting close, but fundamentally, this is an improvement from the back here. You can see the dips are not as bad. These are pretty severe dips, right? So this is definitely better. Functional medicine, fully implemented. He's better, but he's not good. So what we did is we did a qEEG, and this is at 11 hertz. There's a low beta, the thinking band, and you can see here the communication, the dark blue here. This is a depression. This horseshoe here is a depression signature. You can see the front of his brain is really not, the frontal lobe's not communicating. The back is over communicating. You can see the surface areas are unstable, and this is at 11 hertz. So it's not really doing too well here. Okay. His eyes open, eyes closed. We applied the laser. The X's are where we applied the laser. And you can see he's above the baseline, above the normal, right, with laser. And he's maintained this for a couple of years with maintenance treatment. Takes about 2 minutes, about 3 times a week. This is after neurofeedback, did neurofeedback with him, right? And this is after the laser. You can see improvement here in his connectivity. You see the dark blue is pretty much gone. These areas in the cerebellum are gone, but he still has some stuff, but doing much, much better, right? Remember where he started, right? This is at 11 hertz at the same frequency. Clear benefit. So what are the conclusions? Functional medicine is very useful in neuropsychiatric disorders. Clinically, people improve significantly, but they don't actually, at least the population I'm seeing, they don't get all better. The brain function often remains abnormal after the functional medicine treatment. And so you need to have a personalized assessment of specific brain networks, cortical function, nuclei for full assessment and treatment planning of lots of neuropsychiatric disorders. The Hylane KAP technology is very personalized, it's stackable, and oftentimes will normalize brain function and result in full recovery, or at least significant improvement when you add it to the functional medicine, and sometimes without the functional medicine. When underlying pathology exists, like the ApoE4, maintenance treatment may be required, whatever that treatment happens to be. And it's obviously really intensive work, so you have to really go out of your way to prevent this, and that's really what I'm doing. I'm trying to teach people to prevent these disorders. You see at the back of this presentation, there are a bunch of references. If you need to reach me, you can reach me at wholepsychiatry.com, which is like Whole Foods, only whole psychiatry. And thank you for listening. I hope you found it helpful.
Dr. Bob Hedaya, thank you so much. That was amazing, so rich and wonderful. And thank you for the work that you're doing. It's incredible.
Well, thank you for everything you're doing to bring this information and everything in this conference to people. It's a wonderful thing that you've resurrected this conference. So thank you.